All right. So good afternoon, everyone. My name is, as Brent said, my name is Tom Sequist. I'm going to talk to you about two topics that are really important to me: patient experience and healthcare equity. My strong belief is that these two topics are actually inextricably linked with each other, and we can't improve one without addressing the other. So let me sort of make that argument to you and walk you through some of the work that we are doing at Mass General Brigham. And why is this? Okay, there you go. So I have no disclosures, no financial disclosures. So just in terms of the objectives we're going to hit from today, I'm going to talk about how you implement equity and anti-racism in a healthcare delivery system, talk about the influence of equity on patient experience, and get into a little bit around new technologies and programs that can influence both of these concepts at the same time: patient experience and equity. So I always start off when we think about healthcare equity. And it has really been at the forefront of many discussions over the past, I would say, 18 months since the start of the COVID pandemic. But what we should all be reminded of is this is in no way a new crisis. The CDC and other organizations have designated it, I think, appropriately as a pressing public health crisis, but it is not a new crisis. This is a series of stories that were written by the Boston Globe back in 2017, so several years ago, about race in the Boston area. One of the articles was about race and healthcare in the Boston area. And what they show here, and I'm not going to read these quotes directly, I'm sure you can read them yourself, but they really do highlight the experiences that our patients are having. And again, sort of linking that concept of patient experience to equity. And what I would encourage us all to do is, as we read these stories, to not think about whether or not these are anecdotes that may not reflect generalizable experiences across our patient population, but to really reflect on how true and representative these comments really are. Well, I'm not going to review all of the data across our health system and the history of equity and disparities research. I can speak as someone who's done some work in this area over the years, that these anecdotes and these stories here actually do accurately reflect what the data show when we examine our healthcare delivery system. So let's take a step back, though, and not just speak specifically about some of the hospitals that are affiliated with the Harvard system, but a broader context. And let's look at different cities. And I practice medicine here in Boston. There was a survey done that asked African Americans, how welcoming are these cities to people of color? And you can see here that Boston is at the top of this list. We are at the top of many lists in healthcare. This is not a list that we want to be at the top of. We are perceived in a particularly unwelcoming way by Black residents. That's important, right? As a delivery system, as patients are coming into our emergency room, into our primary care clinics, into our surgical clinics, they are bringing this context into the room with them. Another way to view this is to look at the residential distribution of people in the greater Boston area. What you can see here is just simply a density map, but it's really telling, and that you can see that the vast majority of the Hispanic population lives in the northern areas north of Boston, in the Chelsea Revere East Boston corridor. You can see that the Black population lives primarily in Boston, but in the southern sections of Boston: Mattapan, Hyde Park, Dorchester, Roxbury. You can see that the Asian population has larger clusters along the South Shore down towards Quincy. And you can see that the white population in the Back Bay area of Boston, and then extending out into the western suburbs. Now, while I'm not showing you what this map looks like for the entire country, for other large cities, you'll have to trust me a little bit in when I say that many other cities don't have quite the stark distribution that you're seeing here by race and ethnicity. And that also is sort of reflected in this statistic that you're seeing here around what the Black residents in the Boston area are reporting. So what can a health system do about this? And what is a good health system approach in this space? I would argue that a health system approach is layered, and it involves clinical health equity, it involves community health and equity, and it involves structural health and equity. And so let's talk a little bit about what those layers are. So what do I mean when I say clinical health equity? I mean our ability within the delivery system, within the four walls of our hospitals, of our clinics, of our rehabilitation facilities, and of our home care programs, that we address structural racism, that we support a diverse workforce, that we create a welcoming environment, an environment that says to our patients and our community members that we want you to come in here and seek your healthcare here. That we measure and that we act on inequity everywhere, that it becomes a part of what we do, that it becomes a part of who we are. And it drives us to deliver intentionally tailored care for patients. So what do I sort of summarize this all as? I would say that we as a delivery system have succeeded in our clinical health equity program when we have started to treat equity like we have historically treated safety, meaning that we put it at the top of the list of everything that we do. It is our first and primary consideration whenever we launch a program, that we always, when we launch a new program, that we think about the impact on patient safety. I want us to always, when we launch a new program, think about the impact on patient equity, that we hold ourselves accountable to measurable goals like we do in patient safety, that we create a culture that supports the reporting and the acting on acts of equity or inequity or racism like we do for safety with safety event reporting, that we actually staff and resource teams of people who are expert in these areas and whose job is to work on equity like we do in patient safety with our patient safety teams. And then really importantly, one really simple metric when we will know that we have changed the culture of our organization in the favor of promoting equity strongly is that we empower our healthcare team members to literally stop the processes when we think that there is an equity concern here. And you may think that that's a rather dramatic thing to be able to do, but I would say that is exactly the empowerment that we've given our healthcare teams around patient safety. We actually create safety pauses, right? And safety checklists to force us to pause and make sure that there's not a safety issue. I would suggest that we should have those same things in place for equity if we are really elevating it to the prominence that I hope that we all think that it deserves. So that next layer out is community health equity. So community health equity gets more outside of the walls of our 4 institutions and starts to think about how do we incorporate the social, economic, and environmental data that we collect into our routine care. Information about housing insecurity, about food insecurity, about employment status, about other family challenges. How do we incorporate that into our routine care plans? And how do we incorporate that into our community outreach programs as we partner with community and public health leaders? We should do a better job as healthcare delivery systems in creating those partnerships and driving us towards measurable improvements. Putting a stake in the ground and saying, we are going to reduce the prevalence of deaths by opioid overdose by 50% within X number of years. Those are the kinds of goals bold goals that we should set for community health, similar to the goals that we set for ourselves internal to our delivery system for quality and safety. All of this, though, is really honestly going to require us to commit to new models of care. We're going to have to think and act differently. If we're going to incorporate into our care plans information on housing insecurity or food insecurity, well, we probably have to develop the programs that allow us to incorporate that information into our care plans. Do we have the staff available to do that? Community health workers, social workers, resource specialists in behavioral and mental health, other care team members that would be important. Do we have the structural items in place that would be needed to address food insecurity? Have we set up test kitchens in our healthcare facilities that can actually help teach our patients around healthy foods and actually not just the food choices, but how do you prepare them? Are we able to distribute that kind of food as medicine, right? So that medicines is not only prescription medications from the pharmacy, but food is also an important medicine. And have we incorporated those structures into our system? So it really will require us to commit to new models of care. So lastly, as structural health equity. What I think about here is healthcare, as a general rule, is one of the biggest industries in the country. And our delivery system here in Mass General Brigham in Boston is also a large business partner in Massachusetts. We should use that to attract and hire from the most diverse communities. We are a company of 80,000 people. We should leverage our real estate and construction work to stand up better economies in diverse communities and communities where Black, Black, Latino, Indigenous people live and work. We should direct our purchasing that supports our healthcare system in a way that supports these communities. We should work to improve access to care across all of these communities. That includes financial access to care, such as arrangements with commercial payers and contracts, physical access to care, where do we choose to build hospitals and clinics and mobile units, and cultural access to care. Do we create facilities and structures that actually feel open and welcoming to patients when they come in, or do they feel foreign? Ultimately, what we're looking at here is how do you execute a business strategy that is in support of structural health equity. So we have taken our best initial shot at this across Mass General Brigham in a program called United Against Racism. What this program does is it takes three pillars, which are our workforce, our patients, and our communities that we serve, the communities that we serve. We build off of those three pillars to try to drive a broad portfolio that reflects our stance of being united against racism. So in the clinical space, which is what I want to spend a bunch of time on today, we have committed a lot of resources to address what you see on this slide here. And I'll walk us through a few of the examples, and I won't be able to go through in detail all of the examples that are part of our United Against Racism portfolio, but it will give us a sense, give you a sense of the kind of work that we've taken on. We start at the top and we say that it is crucial for us to be able to measure health equity and to measure social determinants of health. That requires an investment to be better at measuring things like race, ethnicity, and preferred language, to be better at measuring things like housing and food insecurity. We have made a lot of commitments to this. We know that the data in our electronic health record right now is not as accurate as we would like it to be. The sensitivity of identifying a Black patient is only 85%, similar with Asian patients. Alternatively, the specificity when we identify someone as Hispanic is only 63%. These data have to be better for us to be able to really drive forward our equity agenda. And so we have set targeted goals for ourselves to improve on missing data and inaccurate data. We are doing that through patient mailings, through email, through telephone outreach, through training of our registration staff. And our goal, as you can see here, is to maintain greater than 90% sensitivity and specificity for all of our data and to have less than 5% missing data across the board. Our next pillar is around expanding access to our care, as I talked about before, through that structural business plan. So we are working on access to care through payer contracting, looking at our commercial payer contracts, through translation and interpreter services, and through digital health. One of the things we learned during the COVID pandemic is that it is critical that we have a more robust language access program. So this is an example through our patient portal where we send emails out to our patients, where we now have more robust translator services in place. And we don't send any communications out to our patients unless they are available in the top 5 languages spoken by our patients. These are things that require significant changes in all of our operations around how we communicate with patients, but do reflect our commitment to this space. Also in the access space is digital health access. We learned early on that digital access was an important component, early on in our COVID pandemic response, I should say, that digital access was an important component of our ability to maintain a lifeline to our patients. But what we also learned early on was that certain patients, Black, Latino patients, patients from certain communities, were not able to access our digital programs in the way that we had hoped. Patient Gateway is our patient portal. It's the way that you access telemedicine visits with us. And what we found very early on is that we had a large difference in enrollment in this portal, which would allow virtual visits to occur by race and ethnicity. You can see that over time, we actually, over the past year, we dramatically increased enrollment in this portal as people were willing to engage in virtual care more than ever before. However, we still have a gap, and we are taking on that gap by hiring what we call digital access coordinators, specific staff who you can think of as community health workers, but on the technical side, who are helping our patients from Black and Latino backgrounds, from patients who live in communities where broadband access is limited, where hardware access may be limited, like iPads and tablets and computers, to get them that access so that they can actually enroll in our digital programs. We're also very committed to the elimination of racism in our clinical protocols and policies. A lot of people call this racialized medicine, is a term that you might hear. The classic example of this is the use of patient race and ethnicity in individual clinical prediction algorithms. So the one example of this is called EGFR calculation. So EGFR being the way that we estimate estimate kidney disease function. You can see in this example there on the right that when we put in for this patient that their sex is male, that they are 75 years old and they have a serum creatinine of 2.5, and we select that the patient is Black, that their kidney function is estimated as 30, we would label them as having, or 30.7, we would label them as having stage 3 chronic kidney disease, which in many cases would not generate a referral to a kidney specialist. If I take the same patient, male, 75 years old, put in their creatinine as 2.5, but I indicate that their race is not Black, their kidney function is now estimated as 25.3. That would probably trip a lot of thresholds to refer that patient to a kidney specialist, which then goes down the road of receipt of a kidney transplant eventually. I'm not going to show you all the data, but we actually have very good data suggesting that when we do such race corrections, that you do end up actually limiting referrals to kidney specialists for Black patients. And we have to ask ourselves, is this an okay correction to be making? There's nothing biologic about race. We actually don't even know, in this example, how the clinician would identify race. Would they do it by inspection? Would they ask the patient to self-report? There are many unanswered questions in this space. What if the patient is of multiracial background? What if one parent was white and one parent was Black? What do you put in any such calculator? Are we revealing to our patients that we actually are using their race to make a clinical decision about whether they should be referred to a kidney transplant specialist or not? I would offer that we probably are not revealing to our patients that that is in fact what we are doing. And if all of these questions are unanswered and we feel uncomfortable with some of the answers to these questions, we probably shouldn't be doing it. And so we have removed the use of race in the estimation of chronic kidney disease, of kidney disease function across our system. And there are many examples where race is similarly used in other prediction algorithms for heart disease and bone density and pulmonary function. And we are taking on all of those issues as well. We're also looking at anti-racism in our clinical policies. One of the things that many people aren't aware of is that when our staff experience racism in our hospitals, it is actually not usually most frequently from another staff member. It is actually most frequently from patients. The patients express racism towards our staff much more frequently than other staff express racism towards our staff. We have to be able to support our staff in those scenarios. We have to be able to provide training on how to respond, provide training on how to deal with those acts of racism, and provide resolution of those events. We are hard at work on reviewing all of our clinical policies to make sure that we can do that. We're also eliminating, as you can see in the lower left, racist nomenclature. So vancomycin infusion reaction being the formal name of a condition where I was a medical student was taught to call it red man syndrome. My personal background is that I am American Indian. That is a fairly offensive term to use for describing a clinical condition. And I can, when you look through this publication that was done by many of the folks in our system, you can actually see that the use of this term actually does prohibit good care from happening because it creates implicit biases, which then lead us to describe certain reactions as allergies as opposed to reactions in the system, which then limit people from being prescribed the appropriate medication in this case, vancomycin. So I'll move on to a program that we call Developing a Culture of Health Equity Improvement across our clinical departments. What are we trying to do here? We've required all 18 clinical departments across our system to engage in at least one process improvement program to address health equity. So across all of our emergency departments, our emergency department leaders are focused on addressing, you can see at the top left there, physical restraint use in the emergency department and race, ethnicity, and language inequities in the use of physical restraints. And we have lots of different departments, as you can see here, working on lots of different areas, whether it be the obstetrics and gynecology department, which is looking at the birthing process and inequities there, or our orthopedics department, which is looking at differences in decision-making for elective knee arthroplasty by race, ethnicity, and language as well. Why do I think this is important? I think this is important because what we are doing here, sure, is trying to address at the same time a pretty massive undertaking of 18 equity improvement projects all at once. But what we're really trying to do is change the culture. We're trying to get through every department across our organization to be thinking about equity every day. Again, if you think back to that mindset around safety, we want them always to be thinking about equity. One of the ways to be doing it is to be always working on an equity improvement project. So the ultimate goal here is really not as focused on the individual projects, but it's about changing the culture, getting everyone used to always doing equity improvement. The next area of our work is around primary care models and developing new primary care models to improve health outcomes. One of the things we know about the pandemic is that it actually had a detrimental effect on quality. And in the ambulatory space, it was very clear. We stopped stopped doing what were perceived to be preventive care services or our less than urgent care services at the height of the pandemic in Massachusetts back in March of 2020. That's going to adversely affect things like hypertension management and diabetes care. And what you can see here from 2019 to 2020, so sort of pre-pandemic and then within the midst of the pandemic, that our quality for patients, regardless of who you are, went down. You can also see here that there were differences in quality between Black and white patients, Hispanic and non-Hispanic patients, and English and non-English speaking patients. But what I would highlight here is the decrement that was experienced by Black patients was 3 percentage points in quality compared to 1 percentage point among whites. For Hispanic patients, it was 6 percentage points of a decrement compared to 2 percentage points for non-Hispanic patients. Why is that so important? Because what we're seeing here is that the decrement in quality was disproportionately borne by Black, Hispanic, and non-English speaking patients. It was in effect harder for them to access care and harder for them to maintain high quality care during the pandemic than it was for white, non-Hispanic, and English speaking patients. What we need to think about is what is a better model of care that provides care for Black, Latino, non-English speaking patients, for patients from communities that were hit hardest by the COVID pandemic. And we have developed a pretty aggressive mobile care strategy where we are, you can see here, one of our community care vans, but these vans we envision to be service lines, rigorous service lines that focus on behavioral health, substance use disorders, and cardiometabolic disease, particularly hypertension management. These vans will be closely tied to our primary care service lines and to the rest of our hospital operations so that they build off of those resources and that they achieve accountable goals. Those accountable goals will be focused on reducing deaths from opioid overdose. They'll be focused on improving hypertension performance metrics. Because ultimately, what we want to do is act on data like these so that we don't have such inequities in performance over time. So I'm going to end there, and hopefully I've left a good amount of time for question and answer. And thanks so much for allowing me to share this story with you.